right. Thank you. God has been good to us, and it's been good to all of you. And what we need to do now is make sure that we do the best we can for those we know who are suffering from breast cancer. We know now from what we've seen on television and what we read in the newspaper that our young black women and our young Hispanic women are dying faster from cancer than anyone else. So we just need to make sure that they get the opportunity to help themselves so they can live as long as they can. So I'm very happy to greet you all here today. And there are some here who have worked with us too. So the ones who have worked to help us put together, let's stand up so we can give you a hand, because that's hard work to some of us. The ones who are here. And there are some people who have worked very, very hard to make sure that she'll tell you about it when she gets a chance to speak, but then you'll hear from Jerry. She didn't tell you all that has been done, but you'll hear some of the things that she has done. So we have a young lady here today who I met, who is a wonderful person. She comes from a great family, and her name is Janine Cook Gurnard. She is an RN, PhD, and a GNP. Professor at Nassau Community College. She has a faculty, she's on the faculty there for that. She has students that she's still training that are nurses. I'll let her tell you a little bit more about what she is famous for. I know she's famous when I first met her, and I heard her, she was with her family, who is a great, great family. And I thought that she would be a perfect person to be here to introduce the people that we have up here with us today. So, would you join us?
Okay. Can we put our hands together and welcome everyone here to this occasion? Please put your hands together. And if you have a program, it says, it is our birthday. This is the 21st birthday of the annual Breast Cancer and Cancer Education Forum. Put your hands together one more time. That is excellent. Excellent, excellent. How important is this moment? How important is this time for us to celebrate the blessings of God for us surviving breast cancer? I saw so many stand up that were survivors. Put your hand up again. Those who know someone or are breast cancer survivors. That is amazing. It's amazing. I just want to honor very quickly, and I'm going to tell you something that our Deputy Supervisor, Dorothy Goosby, for this 21 years doing this. Can we honor her? This is a great work that is being done, and it is needed, it's needed, it's needed. And thank you so much for allowing me to host this most auspicious occasion. It is such a blessing to be here. I'm going to introduce our panel right now, and a lot of our professionals and breast cancer survivors are here to talk to you about breast cancer. And some of the things that you don't know, and some of the things that you might have questions about, or even things that you know, and you're just reinforcing the information that you've heard before. But this is a time where we're going to really dig deep, engage, and talk about breast cancer. The first on our list we just want to introduce is our Dr. Irina Gelman. Dr. Irina Gelman, give us a wave. Nassau County Health Commissioner, and she is here to talk to us. Dr. Helen Pass.
No, Dr. Gelman is the commissioner.
Oh, okay. Dr. Gelman is the commissioner. I'm reading notes that we're given. Okay, so let's read out of this program. Okay, Dr. Michael Seidman. I have him as a physician at Mount Sinai. Is that right? All right, let's put our hands together for him. He is one who practiced surgical oncology with a focus of breast cancer since 2013. So he's going to give us a lot of information about the breast cancer surgery. Okay, let's start again. Dr. Helen Pass Is that right? Okay, NYU Langone, one of our main hospitals in Nassau County, also breast cancer surgeon. Amen. Thank you for being here. That's excellent. And also we have our Jerry Barish. Okay. All right. She is the president, the Long Island Breast Cancer Action Coalition Executive Director, Hewlett House. Am I right?
Right.
Excellent, excellent. Come on, welcome her as well. And last, certainly but not least, Irina Gelman, the Nassau County Commissioner of Health. All right, so we welcomed you twice. We also have on our panel today two people who we really want to honor, and these are breast cancer survivors. One is Amanda Fitzpatrick. She's a two-time survivor. And endometrial cancer survivor as well. Wow. Okay, along with Tanya Herring, another breast cancer survivor. All right, so we thank you all for being here today, and we're just going to start out with answering a few questions, and anyone that has the answer, you can answer it in any order that you want to answer it. We know that in Nassau County in particular, that there is an increased incidence of breast cancer. Can you tell us how Nassau County or Long Island is faring with breast cancer?
I guess I'll jump in on
Yes.
As we've established, good afternoon, everyone. I am the Health Commissioner of Nassau County for the fourth time today. Thank you very much for the introduction.
You're welcome.
As far as Nassau County, we do see higher rates of female breast cancer compared to New York State as a whole. So as far as statistics and what that looks like, we see 189 versus 164 for the rest of New York State per 100,000 population. So we do have a higher incidence specifically of female breast cancer compared to the rest of New York State.
Well, anybody else want to add to that? Doctors, how prevalent it is in Nassau County? How many patients are you seeing in your offices with breast cancer or needing surgery for breast cancer?
I'm going to laugh because since we're both breast surgeons, that's what we see every day, unfortunately. I mean, it's still 1 in 8 women. I'm unfortunately old enough that I remember when it was 1 in 12 women when I was in med school, then 1 in 10 women in training, and now 1 in 8 women in my practice. I wish we knew why the rates were increasing. There's definitely a large environmental component, but there's a lot of lifestyle choices we're making that increases our risk for breast cancer as well. And so that'll probably be a touch point in a few. It's not just Nassau. I came from Connecticut, which borders on the other side of the Sound. And Connecticut's a really small state, so our per capita breast cancer was always one of the highest in the United States. So even though we didn't have the largest number, we had the largest percentage of patients with breast cancer. And so it does make you wonder what's going on.
And I just want to add to that. Part of the reason I believe that the incidence has increased is because people like Dorothy and Jerry are getting the word out, and people are going for their screening mammograms. And so while the actual incidence may not be fully attributed to environmental factors, the fact that we're finding it and more women are going for screening, I think definitely plays a role. We also have newer mammogram machines. We have something called 3D mammography, higher resolution. And so we're able to detect cancers at even an earlier stage. And it just shows the importance of going to get your screening mammograms. So there are definitely environmental factors at play, but I think the fact that incidence is increasing is a testament to the fact that we're on the right track here by getting the word out. All women should be getting their screening mammograms.
So talk to me about, you talked about some prevalence in Long Island. What seems to be, or has it been isolated, or any research as to why Long Island has a high incidence of breast cancer? Is it the food? Is it the water? What are we finding?
So I'll jump in first, just
Yeah.
as far as to set the tone as far as statistics. As was just mentioned, between 2017 and 2019, 69% of women aged 50 to 79 in Nassau County had a mammogram. So obviously increasing incidences do play the actual expansion of testing and access to care, Long Island has phenomenal access to care. So the more we get the word out, the more individuals are getting screened. So we are finding cancer earlier on. So the fact that we have slightly higher incidence rates of occurrence, there is a factor with improved screenings, having access to testing, and having access to care. Now, we all know that cancer is multifactorial. So as you've mentioned, there are environmental factors, there are day-to-day activities of daily living and choices that we make that may potentially contribute. But besides the multifactorial nature of it, we can't walk 2 blocks in Long Island without having a healthcare system, so we're fortunate in that regard. And that increased access does play a role in discovering cancers early with increased screenings. With that said, we do want to promote and ensure that everyone has access to screenings. We do have, as was mentioned earlier today, a mobile van right outside for free screenings that are available today, right now. And we do want to promote screenings. Please make sure, if you have not had your screening already, if family members have not screened, make sure to get those screenings early, because that early detection is key to really ensuring that you're getting earlier care and we're having fewer deaths from cancer. Thank you.
So I have to jump in. When we started out, the rates were we took 1 in 9 because that was the national instance of breast cancer nationwide. And we learned about screening and the importance of screening, so on and so forth. Bringing us up to date, lacking is education, is a true outreach and education of who we are, where we come from, what we live on, yes, what we eat, and all of the rest of that. We have people every day that come in to Hewlett House and say, how did I ever get breast cancer? There is no cancer in my family. And when we sit down and talk to them about breast cancer as a hormonal cancer, and there are other cancers, for instance, your father, an uncle, a brother in the lineage line that have prostate cancer. Prostate cancer is a hormonal cancer. Sons, daughters are coming down with breast cancer. It is knowledge. We need to get this information out. We need to make people understand what the word history means, that you have, each one of us that we know, can find out about our family history, not just breast cancer, any kind of cancer on either side. That is so important. We have genetics today. When we started, we didn't even know what the word genetics meant. It is so important to know that you could be possibly predisposed for a cancer and get screened. The big issue we have today is young, so that we're told you can't go for mammography if you're under, at one point it was under 50, then 45, then 40. If you know that you have a predisposition, if you know that there are other cancers, if you know enough about yourself, and you speak with your doctor, you can be screened. You need to be screened. The more information, the more education that we could give you is so important.
So how early should I get my mammography? What age should I start? Particularly whether I have breast cancer in my family or not. What is the age?
Yeah, so if you consult Dr. Google, and you'll find that there are so many different guidelines out there. But my opinion is that all women should at least start at the age of 40 annually, and I would not stop getting mammograms ever. There are a lot of primary care doctors that will tell you once you reach a certain age, you don't necessarily need a mammogram anymore. And I think that's kind of ridiculous. As you get older, your chance of getting breast cancer increases. Right. And our ability to detect breast cancer gets better because as you age, your breasts become more fatty, so it's easier to find cancers. We can find it earlier. And even if you have a lot of medical issues and undergoing the knife might be risky, we don't necessarily have to treat it with surgery. There are medications we could use to make sure that it's not breast cancer that takes you off this planet. Now, as far as patients that have a strong family history or have a genetic mutation, we'll start with the family history. I counsel my patients to start 10 years before the youngest relative's diagnosis. So if you have a sister or an aunt who is diagnosed, or a mom who is diagnosed at the age of 45, then I would start screening at 35. And not to mention, these patients should undergo genetic testing. Now, if you are found to have a genetic mutation, and there are different genes. There's not just the BRCA gene. There's a panel of genes that we test for in today's day. Then I would say you would have to start screening as early as 25 years old with MRI and ultrasound, and then starting mammogram at 30. And so it's very important, just to echo, it's very important to understand your family history because, it's actionable as young as 25 years old.
So I know at 25, although the breasts are very dense, 25 is if you have a family history. So is that first generation breast cancer?
Yeah, so that's for patients who actually have a genetic mutation
Okay.
that significantly increases breast cancer, such as BRCA1, BRCA2, PALB2. There are a few. And to your point, yes, your breasts are going to be dense when you're younger. That's why we don't start with mammograms right away. We start with screening MRI and ultrasound. And by the time you reach 30 years old, then we'll start the mammograms.
So I'm just going to add a couple of the stories of the breast cancer survivors into this piece of when did you find that you were positive for breast cancer? And my question is directed to Amanda. When did you and how did you find out that you were positive for breast cancer? I think turn your mic on.
Hi, everyone. Good afternoon. Actually, my cancer wasn't breast cancer. It was endometrial cancer. But I fight for all. So when I first was diagnosed, I was 26 years old. Yeah. I went to, did all the medication, I did everything, and then they just pushed me into this room, and it was nothing but elderly women, no offense to them, as a support group. And I'm 26, but everybody's like, could be my grandmother's age or older. And I was like, I couldn't fit in. After 2 sessions, I asked the facilitator, is there a young people's group? Because the only thing I could relate to is that we have the same cancer. And after 2 sessions, she said, okay, that's a great idea. And my group, which I made, was called We're Too Young for This, the Young Women's Gynecological Cancer Group, support group, where it's no therapy, it's just a place to hang out and do activities and just be outside or inside. Well, now we're virtual due to the virus, the coronavirus. We're now back outside, and we're just enjoying life and dealing with cancer all at once. So now I'm a 2-time cancer survivor of endometrial cancer, and I just thank God to be here. It's amazing how I see God work within me, because all I had to do was just pray, and He made it for me to be here 2 times. I mean, gave me like a 3rd chance at life, because it's like cancer and then hearing cancer again, and it's like going through all the treatment and surgeries that I had. It was horrible, but I made it, and I thank God. So thank you for this opportunity.
Yes.
I am here to fight for everyone. All cancer is cancer for me, so, I like to say cancer is not a death sentence. Don't be afraid. Just go through with it and pray to your higher person, God, whoever His name is. His name for me is God, but you pray to Him, and He will bless you. So I leave you with this. Cancer is not a death sentence. Just go through it, fight, and continue to support, and just be here, and be thankful, be in the moment, be present.
Yeah, thank you for that story. That's a great story. Would you like to share also?
Well, One second, I just wanted to echo her "don't be afraid."
Yeah.
That's a barrier to so many women getting their mammograms. They're afraid we're going to find something they don't want to know. And so I always tell people at the end of these events, if you haven't had your mammogram, please do, but reach out to the important women in your life and see if they've had a mammogram in the past year. Because as he said, early diagnosis makes a big difference. It doesn't necessarily mean large surgeries. We've got many options nowadays. Our cosmetic outcomes are better. Our lymph node outcomes are better. It's very complicated, but very personalized now. The same treatment's not right for everybody. But the biggest hurdle is getting women to go have a mammogram because so many say, I'm afraid of what you are going to find. So you got to overcome that fear. And then, as she said, if you are diagnosed with cancer, you've got to find the courage to confront it because there's so many options we have nowadays that it's not a death sentence.
Yeah, that's so true. I mean, I know that a lot of women, they defer getting the mammogram because of the fear of the diagnosis or the fear of the outcome of that result. Yeah, so please share your story about breast cancer.
Good afternoon. I am a living testimony of early testing, early diagnosing. So what you're hearing here is not just doctors giving you information just because. What they're saying is actually true. I actually have always been on top of my mammograms. I actually started before the age of 40. I have no family history of it, but just being in healthcare for such a long time, it was just important for me. But that's not even how this happened. My early diagnosis came because of the pandemic. It was August, and I wanted to get out the house. And they happened to be open, and I said, I'm just going to go get my mammogram done this time anyway. And so I went, and it started with calcifications being detected, and after a series of testing being done, it was Halloween Day, 6:30 p.m., 2020, sitting on the end of my couch when a breast surgeon called me and said, hey, good evening, just wanted to let you know that you have breast cancer. Call my office on Monday. Talk to you later.
Wow.
And that was how I found out that I had breast cancer. And that is not something that you want to hear when you know the outcome of most breast cancer, right? You know, people survive, they fight, and then they die. And to hear that and you don't know what stage you're in and you don't want to share that with your family. But I had to be encouraged. I had to encourage myself. I had to be strong, and I had to encourage myself. I had to be an advocate for my health. I had to fire that provider. I had to be an advocate for myself. So if you don't learn anything else today, remember this. You have to advocate for your own health care. Not every doctor is for every patient. Not every patient is for every doctor. But that doesn't mean that your doctor isn't out there. You have to be strong and courageous, speak for yourself, advocate for your health, and don't take no as an answer. Don't take don't as an answer. You are a fighter. You are a survivor. You are a thriver. So all you have to do is say, okay, this is what I did. Okay, as the tears fell down my face, okay, I know a whole bunch of women who are surviving cancer. I stand on some good shoulders. So it's my job to pull it together and fight. And before I told my family, I had a plan. I had a new set of doctors. I had one of the best oncologists. I knew that at the end of the day, no matter what happened, however long my journey is going to be, I'm going to be a fighter. And on March 26th of 2021, I was diagnosed breast cancer free.
Wow.
So when these providers tell you that early detection is the key, it is so true. Early detection is your key to your survivorship.
Yeah. I just give you a hand for that one. That was a wonderful story. So when we're talking about detection, talk to me about self-breast examination. How often should we be doing our watching and palpating for lumps in our breasts? When should we do it? And what areas should be included when you're talking about self-breast examination. Anybody can talk to just
Okay, so.
part of prevention.
You always love to hit the controversial topics. The American Cancer Society got rid of the recommendation for self-breast exam. They stopped distributing shower cards, and they really started to say, focus on self-breast awareness. So I always tell people it's a little weird because most of us have 2 of these. They're free, we've got them, we should use them. And so I tell people, we're not focusing on self-breast examination because we don't want to tell somebody, what do you mean you didn't find that and you're not been doing your exam every month? Right. So the flip side is we all bathe, we all wash, we all shower, we all put on lotion, we're all putting on garments, so you should pay attention to what you're doing. Now, for most women, it's easiest to examine themselves in the shower because everything's slippery. But for women who are bigger chested and their breasts, I don't know how men surgeons get away with saying these things, droop. It's a little hard to make sure you get the whole tissue if you're doing it standing up. So we say a couple of things. When you're in the mirror, you should look. Make sure there's no puckering. Make sure one side hasn't gotten larger or smaller than the other side. Make sure your nipple, if it was an outie, hasn't become an innie. Actually tense your muscles. Make sure you don't see any pulling or tethering or dents forming. It's easiest usually to examine yourself lying down because that flattens the breast tissue against your chest wall. And so you want to use gentle and then hard pressure because you'll miss things with pushing too hard, you'll miss sometimes the subtle things. Pushing too light, you'll miss something that's deep down. You also just want to be aware. The things that resonate with me is when a patient goes, I've always had lumpy, bumpy breasts, but I don't know. I was on the phone and my hand hit my breast and this feels different than anything I've ever felt before. Or I was putting on lotion and I went, what's that? Or my partner reported that they felt something. And so again, it can be discovered in many ways. You're not a bad person if you haven't done your self-breast exam in the last 3 years because the guidelines don't recommend it, but please be self-breast aware.
And with that, I don't know, you want to add something to that? Sure.
Yeah, can I just?
Yes.
Well, I am a believer of self-breast exam, and that's how I actually found mine the first time. Didn't even think anything because it was up on my clavicle, and then I found out that breast tissue can go right up there, so it is.
And under the arm as well, right?
Right. And most lumps are found by husbands, by boyfriends. I mean, you need to know your body. You need to know that if something bothers you or you find something and you're unsure, you need to call your doctor. You need to check this out, anything and everything. I think it's very important. We're our own advocates. When we talked about doctors, I think it's so important to have confidence for your doctor. It's very important to have that relationship that you can relate to your doctor. I find that my doctors kept me alive for 5 times I've had cancer. And that's how my confidence is with them. And they're out there. We have great doctors. You don't have to go to Park Avenue to get the best. We have it right here. But education is so important to understand who you are, where you came from, and to know your own body. And if something bothers you, I don't care how young you are. If something's there that wasn't there before, it needs to be checked out.
Yeah.
And I will echo also, don't settle for false reassurance. So there's 2 things. You feel something, you're supposed to get your mammogram, so you don't tell them. You're like, I want to see if it's real. Let me see if they find it. No. You point out everything, because they're going to take extra pictures of that spot. So I have a lot of women who go, well, I felt something, but I wanted to see if they were going to feel it. Same thing. You're going in to see your provider. If you notice a change, tell them, you know what, this is different to me. It really does help guide it. The flip side is if you feel a lump in your mammogram's normal, don't let them tell you, well, that's okay. Mammograms miss 10% of cancers. That's just the raw, unfortunate truth. It's the best test we have, but it's not the end-all, be-all test. So I wouldn't say that if a woman feels something and she's told, well, your imaging's normal, don't worry about it, that should be the end. So when people are saying advocate for yourself, that's when you need to say to your physician, well, so what are we doing next? Because I'm not really comfortable doing nothing.
Did you want to add?
Yes, please. So to quantify what has already been said and to put it into a relative context, it's extremely important, the importance of early screening, of self-detection, of knowing your body. But to translate that into numbers and what we're seeing, 99% of women diagnosed with breast cancer will survive as of 2023. So as of 2023, there are 3 million breast cancer survivors in the U.S. today as a result of earlier detection, both through increased awareness, as we've heard, education, self-awareness, and mammography screenings, as well as advances in treatment. The death rate from breast cancer dropped by 42% from 89 to 2019. Between 2017 and 2019, I have mentioned that Nassau County has fairly high rates of screening for women aged 50 to 79. However, I wanted to highlight this. There are racial disparities among survival rates of breast cancer and late-stage diagnoses between Black and white women, and this is the reality that we see in Nassau County as well. Black women are 41% more likely to die of breast cancer than white women overall, and are twice as likely to die if they are younger than age 50. So those are staggering statistics. It's extremely, extremely important that you go to your doctor, speak with a trusted friend, doctor, and actually go for that screening. Breast cancer has surpassed lung cancer in deaths among Black women. So these statistics are very alarming, and we're hoping we're hitting the message home for screening, self-awareness, speaking with your doctor, because this is something that we can prevent together.
So when you talk about the disparities, particularly in the African-American population, we know that prevention is very important, is key. So are we seeing more people going to getting their mammographies? Are we seeing more people going to their health care providers and finding themselves where they're catching it early, catching the cancer early before, right, they really get into a metastasized cancer? Are we seeing that?
So yes, we are seeing some information. Information is improving. As we get more information and education out there into communities, hopefully you're taking the information that we have available outside home, speaking with your family members, speaking with your community members, and really honing in on the message, please, please get your early screenings. And there are caveats to what we're seeing. Women who are underinsured or of low socioeconomic status also have lower survival rates of breast cancer. So there are a lot of factors that play into the death in the death sentence that has been mentioned before, but we can take action. We can all prevent this. So please, please speak with a loved one, speak with family members, friends. Just get the message out there that we do have the access. We are fortunate enough to have that medical care access in Nassau County. It's just a matter of that final mile, getting there, speaking with your doctor, advocating for yourself, and knowing your body. Thanks.
We talk about women, but what about the prevalence in men? Doctors, are you seeing that you're doing surgery with men that have breast cancer as well as women?
Yeah, absolutely. About 1% of all breast cancers are going to be found in men, and men, don't get screened, so it's typically going to be found on exam. And men tend to not do as well as women. The reason behind that is because they're not getting screened, and we're catching it at a later stage in men typically. And a lot of times they're in denial. And as we all know, men are notorious for not wanting to go see the doctor. I'm guilty of that myself, but stage for stage, men versus women, when it comes to breast cancer, outcomes are identical. So it really highlights the importance of, if you see something as a male, say something, go see your doctor, get it checked out. Breast cancer can definitely happen to you. Last year, about 500 men in the U.S. died from breast cancer, so it could happen.
So again, and just to piggyback on the statistics, to echo the sentiment, in the U.S., an estimated 290,560 people will be diagnosed with breast cancer. So as far as statistics and how they fall out, 287,000 women and 2,700 men. So we are seeing men, and as the doctors have mentioned, again, same messaging, screening, conversations, and actually getting to the doctor.
I like to keep things simple, so 1 in 8 women, 1 in 800 men. That's sort of the easy statistic.
And it's all
Technically, 1 in
significant,
833 men, but
Yeah, all significant.
I'm
Yeah,
sorry,
sure.
Dr. Haas, interesting when you put it like that, but when you go county by county, which is what we've done for so many years, the numbers change. If you look at and speak to doctors, you speak to scientists, they say at one point, we were 1 in 3 in breast cancer because there wasn't enough screening. There wasn't the early detection. We didn't know what we know now. We've come so far, but we can't forget the younger and younger people, and a lot of times they have problems screening. We're still fighting with getting men to be allowed to be screened on our mammo vans. And that's going back, I don't know how many years ago. There's no reason for that, but they have to have a prescription, they have to go see a doctor, they have to go to a radiologist. So we started a program many years ago and said, okay, take your husband for mammography. You'll take him out to dinner. Make him go. Do it as a gift. Make up a simple, silly little thing.
Like that.
And for a period of time, it worked. I mean, I was 39 when I was first diagnosed. So it's very important for us to talk on both sides and get families and get husbands and wives and our men. The rates are going up. A lot of men don't talk about it. We have to get that. It's very important. And if you know your history, I'm a big nut for history because of the hormonal situation. And then you could look at both sides and talk about it and advocate for the education.
Yeah. You wanted to add something, Doctor?
I was just going to say, and the incidence is unfortunately increasing in men as well, so they're not immune to the increasing incidence of breast cancer, just like in women.
Talk to us about surgeries. I know there's a lot of cutting-edge surgeries that are now available for persons who are diagnosed with breast cancer. Can you speak to that? What are you
You can go
Cutting
first.
edge.
Are we here till 5? How long do we have?
You have a lot, right?
If you look at the treatment of breast cancer over time, it's been quite remarkable how we've been able to de-escalate the amount of treatment, specifically what we call local regional treatment, so that's surgery and radiation, while still improving patient outcomes. And this is due to the fact that we've had widespread adoption of screening mammograms, because we're able to catch the cancer before it becomes symptomatic. Then once you do that, you have all options at your disposal. The old-fashioned way was something called a mastectomy. We still perform this procedure today. This is where we remove almost all the breast tissue. We get about 99% of the breast tissue. And typically you could get reconstruction done by a plastic surgeon at the same time. Well, going back to the 80s, we figured out that if we're catching these early, we started to question, well, do we really need to remove the entire breast to do this? And the answer to that is no. And so one of the major trials looking at this compared patients that had total mastectomy to those getting something called a lumpectomy, where we just remove the cancer with a rim of normal tissue around it. And then those patients would go on to get radiation. And what we found was that survival between the two operations, stage for stage, was identical. And the chance of this coming back was slightly higher in the lumpectomy and radiation group, but still very low. And so these are going to be your two main surgical options for treating breast cancer.
But I'd like to say we've come a long way since then as well. So we used to do mastectomies with big incisions. Now we can hide the incision in the fold. We used to always throw away the nipple. Now for appropriately selected patients, we talk about preserving your own skin, preserving your own nipple, saving the envelope for the plastic surgeon. We used to do lumpectomies and people would have a shark bite and they'd get their radiation and it would be all firm and tented in. And now working again in conjunction with our plastic surgeons, we can do what we call oncoplastic, so the cancer part with the plastic part, and look at the cosmetic outcomes for lumpectomies as much as we look at it for mastectomies. So women are living longer and longer after breast cancer. That's our goal. So we want them to live as whole as possible. And that comes from really giving them back their breast shape. Same thing for lymph nodes. People who know people from the generation before know the women with the big swollen limbs, and we don't have to do that anymore. We can be selective in the lymph nodes we remove, and we can even now in some patients be so selective we don't need to remove lymph nodes. So that's why I go back to don't be afraid to get your screening mammogram. If you find something small and early, or even if you feel something so you're like, oh, it's not going to be early, it's over for me, the answer is no. We've got lots of options. You used to look at the pros and cons of lumpectomy versus mastectomy, and most of the things that they used to say, oh, you have to remove the whole breast, we're slowly ticking them off. Nope, we can remove the nipple and keep the breast. Nope, we can do 2 spots now, 2 lumpectomies instead of removing the whole breast. You know what, even if you've had a lumpectomy and radiation, certain patients can have a second lumpectomy and radiation again. That used to be, oh, you've had it once, you can never have it again. We're getting data on pushing the envelope on all of these. So I still go back to don't be afraid of what you're feeling or what you're thinking the mammogram's going to find, because we've got so many more options that, you know, our surgery is much less drastic, much less mutilating, much more focused on outcomes, both functionally, cosmetically, and, you know, spiritually and personally, emotionally. It's a huge journey.
So when you have surgery, whether it be a lumpectomy, you don't do radical mastectomies anymore. That's very rarely done. Is that right?
He's younger than me, so I will venture to say he's.
And how rare is it to have a female surgeon, I should say, first of
We're
all?
increasing in numbers all
That's
the time.
good. That's good to see.
I will tell you, I've done one in my life, and it wasn't even for breast cancer.
Okay.
So, like, we don't do radicals anymore.
Okay. So when you're talking about breast surgery, lumpectomy, mastectomy, is that always inclusive of radiation chemotherapy? Or can we do just the surgery without having the radiation chemotherapy? Anyone can address that.
Yeah, so I'd like to separate chemotherapy from the radiation and surgery piece of it. We take a multi-pronged approach to the treatment of breast cancer. The surgery and radiation is to treat local regional disease, we call it, where it's just the cancer in the breast. The chemotherapy piece is to treat the bloodstream. Unfortunately, when you have invasive cancer, there's a chance that 1 cell or 2 cancer cells can make its way into your bloodstream. And we don't, unfortunately, have a test that tells it that this has happened. And depending on what type of breast cancer you have, you may need chemotherapy. And the goal of that chemo is to find those rogue cells that might be in the bloodstream and kill them. As far as radiation...
But before you go there, what surgery you have doesn't get you in or out of chemotherapy. We have many women who go, well, just take my breast and then I don't need chemo. No, no, no. If you need chemo regardless of what surgery we do. Breast cancer is not one disease. We keep throwing out these terms like triple negative. It seems to be one of the more aggressive cancers that affect our women of color, and that's one of the reasons their outcomes are worse, because we only have chemotherapy. We don't have pill forms of therapy for that. But for other cancers, our most favorable type of cancers, we now have tests on the genes in the cancer. So sort of a precision medicine that in the old days we would say your cancer was this big, or oh my gosh, you have cancer in the lymph nodes and you need chemotherapy. But if you have a very specific type, estrogen and progesterone receptor positive, HER2 negative, also what we call a luminal A, but in other words, the good actor, we can look at the genes in your tumor and independent of size, independent of lymph nodes, within some parameters, we can now say, oh, no, we would have in the past given you chemo and now you don't need it. Or the flip side, in the past we would have told you were going to be fine, and then you might have been one of those women who came back and the cancer came back because we undertreated you, and now we know the side effects are really worth the benefit. So what we recommend for head-to-toe or systemic treatment is independent of what surgery you get, so you don't get in or out of it. Okay, take your radiation away.
Yeah, sure. Those are excellent points. And, you know, I just want to add that the good actor, the luminal A, estrogen and progesterone receptor positive, HER2 negative breast cancer is the most common that we're seeing. So the amount of patients that are requiring chemotherapy these days compared to not too long ago has significantly decreased, especially with this new genetic test that we perform on the tumor.
Yes, so we're really looking at that biopsy. We really are looking at the tissue, the cell itself. and also the imagery to really see how we're going to treat that breast cancer. That's what we're really looking at. That's why really prevention is so important, that
No,
we really are
correct.
testing.
And, we're learning that we're using tumor biology to drive decision-making regarding systemic therapy.
Yeah.
When it comes to local regional therapies, this is surgery plus or minus radiation, we've also de-escalated in that regard. We've de-escalated with how much surgery, as I mentioned before, mastectomy versus lumpectomy. But we've also selected out certain patients that may not see a survival benefit from radiation, as Dr. Pass mentioned. Certain patients with the luminal A type of breast cancer who are over the age of 70 don't necessarily require radiation. There are certain patients over the age of 60, if they have, a small tumor, we can perform something called intraoperative radiation, which is done at the time of surgery, and then they don't need any more radiation after that. So the number of patients requiring what we call external beam radiation has been ever decreasing as well.
Have you heard of patients that ask you a question of, do I have to have surgery? Is there any alternative kind of outside of the surgery, realm? Is there any particular food that I can eat or ways that I can eliminate the surgery process or chemotherapy or radiation? Have you ever heard of that?
Defer to them for everything.
Yeah.
But, so that is the most common questions that come to us every day. Do you think I really need surgery? I'm not a doctor. You need to discuss it with your doctor, write everything down. What do you eat? What shouldn't you eat? They say if you eat a lot of broccoli, you're not going to get cancer. A lot is fallacy. A lot is internet. Be very careful of the internet because it's not about you personally. It's general. And people they come and they say, you know what? I read about this. How come I'm not on it? It's general. You need to talk to your doctor. You and the doctor will make the right decision. But all of these questions, am I too overweight? Am I underweight? What do you think? These are great questions. Keep a diary. Ask those questions to the right person who understands you, your body, your age, all of those things. We are living longer and longer. Research is one of the most incredible things that has happened on a daily, every second basis. We find out more and more. I listen to the surgeries. I mean, if I had to get cancer, I wish I would have had it now as a new diagnosis than I did when, because it's so different now. Your treatments is so different. Your outlook is so different. It's not a death sentence. It's really, really not. And the fear, when you look at someone, I understand cancer is a very scary word.
Yeah.
And it's okay to be frightened, but once you get the right information and you talk with other people that have gone through, that old saying, walk in my shoes, it's true, walk in my shoes, but it's not necessarily cut off the right arm. You may have half a left arm. Ask the right questions, and you will get there. Thank you.
Do you always have to have general anesthesia with the new surgeries that are out now? You talked about lumpectomies. Do we have to do general, or is it more regional?
With mastectomy, we're still typically doing general anesthesia, but with lumpectomy, I rarely do general anesthesia for that. In fact, I had one patient who refused any anesthesia.
Wow.
She only wanted local, and she was talking to me throughout the entire procedure. That's not typically the way I'd like to do it, but what we'll typically give is something I call twilight. If you've ever had a colonoscopy, it's similar medications to that. You'll be sleeping, but you'll be breathing on your own. You won't be on the ventilator.
And so a shout out for colonoscopies, since we're doing general health. The age has now dropped down to 45 for your first screening.
Yeah.
So all of you who haven't had your mammogram, if you haven't had your colonoscopy, can I put that on your to-do list as well? I'm a bossy little thing, sorry.
You're bossy. Okay, so what about reconstructive surgery? We talked about, years ago, we did implants. Are we still doing implants for those individuals who are having more of a radical type of mastectomy or surgery?
The nice thing is we have choices. Women have many more choices. Some can use their own tissues, some still want implants, some don't want any reconstruction at all. Again, the going flat movement is very real and very alive. We now know how to do that better as well. So we used to leave a lot of extra wrinkly skin for women who didn't want reconstruction, and now we know we can make it a nice, smoother chest wall for them to have their prosthesis. And there's many reasons women pick what they want to do. Men can also get reconstruction. I don't want to forget them. They often have central tumors. We can reconstruct their nipple. They can get chest wall recontouring. If there's somebody who's feeling self-conscious in their athletic clothes or want to be able to be outside without a shirt on, men never used to get offered reconstruction, but they can get it as well, and we shouldn't forget them.
So talk to me about support. That's one of the things that I think is that our survivors were talking about in terms of what kind of support is out there for someone who has been diagnosed with breast cancer. Is this support in the hospitals? Is it in the communities? Where can women and men find support, whether it is for the family or themselves?
I got one.
You got that?
Right.
Okay.
That's right. My friend's down there.
Yeah.
Support is so important. There are numerous organizations all over the place that run support groups. There's one-on-one. They meet in groups. Hewlett House, for instance, we have all kinds of support groups. We have a doctor on board, a psychologist, an oncology background. We can refer. We can get you to the right place at the right time. We're a totally free service. It is very important to be able to, if you want to come and talk to someone privately. We understand not everyone is ready to get out there and just spill everything they have in front of a lot of other people. Support groups are not for everyone. But it's very important to know that you do have this support. People say, can I see your scar? Do you have a scar? Absolutely. That doesn't mean you're going to have a scar. Mine was done so many years ago. Yours, different today. Support is right there, and we are available 24/7 for everybody that needs us, that has a question. Never hesitate to call. We'll always call you back. There's so many different organizations, wherever you live, in every town, in every community. We get a lot of people from the 5 boroughs. We have a group that comes to us from Queens. They now don't need that day-to-day support anymore, so they get together, they take the needles and the wool home, and they crochet and knit together. They still have togetherness, community. They rely on each other. It's a special, I call it a special sisterhood nobody really wants to get into, but we do. We have it, and we're available. We have millions and millions of hugs, thousands of tears, but they're us together, and we're a family.
That's great. Anybody else with support?
So as Jerry has mentioned, there's a wealth of support services available in Nassau County. We have over 11 hospitals. All of the hospitals have some sort or shape or form of support services available. There are many community organizations. If you have questions, by all means, contact the Hewlett House, contact the Nassau County Department of Health. We do have information on community services, hospital services. If you don't want clinical or medical-based support services, there are other options within the community that are more private, more faith-based. Yes, so there are a lot of services available and here for you. And of course, your families. That's our family is probably the primary support structure, but the communities here, our faith-based services, our hospital systems, we're very fortunate in Nassau County.
Yes.
But I wanted to echo the family. Don't forget that they need support too. So more and more young women are being diagnosed and their children need attention, and you need to focus on what their support needs are. The caregivers need support too, because they're feeling isolated. And I think we've recognized that and tried to have a ripple effect where we're not just supporting the person with cancer, but we're supporting their whole network. And so those support systems exist. And I really want to give a shout out for the person who said, there wasn't a support group for me, so I started my own. If 1 in 8 women are getting breast cancer, there's going to be more people like you who are not getting their needs met. So if it's rock climbers for breasts, go make it happen.
I just want to add, a cancer diagnosis is just not for the person being diagnosed. It's also a diagnosis for your family, because the support is so important. I had a wealth of support, not just from my mom and my sisters and my brother, but also from 2 different church families that I had, actually 3 different church families. That is so, so important. I had a team of women that prayed for me every single day. And that meant a lot to me, even though I couldn't hear them, I couldn't see them, but that meant a lot to have that added support. I just also want to add that I am honored to be sitting here this morning with 2 providers who are providing you with information that my provider put on the table. Everything that you've said. So I've had to go through, I had a lumpectomy, and unfortunately, they tested the tissues around it, and there was some stage 0 and some stage 1. And so then I had to go back and have a mastectomy done. And so everything that these 2 wonderful providers told you, and I know we're being recorded, and I'm going to go out on a limb and say this, I am a part of the NYU Langone family, because those are where my providers are from. However, I am a big supporter of Mount Sinai as well. So, yeah. Because what happened when I had the other provider that I had to fire, and get used to that word, because you are allowed to fire your providers when they're not providing for you. The one I had to fire is not being represented right now. I want to make that clear, right? But I relied before I went to NYU, but I had an opportunity to speak to a provider at Mount Sinai and at Sloan Kettering to get second opinions. And it was simply, send me over what you have, and I'll call you back. Both of them did that, and it was awesome to say, your provider, they didn't try to steal me from my provider. They said, your provider is providing you the proper medical care for your diagnosis. And that, do not be afraid to get a second opinion. Hey, mommy. Do not be afraid to get a second opinion. Do not be afraid to advocate for yourself. And most important, if you trust your provider, listen to your provider, because they're going to set you up with a team. You're going to have your surgeon, you're going to have your oncologist, and hematologist. They become your second family. I listen to my providers because their job is to keep me alive, and my job is to stay alive.
That's right.
Okay.
All right.
You are so right, 100%. We have the best of the best here. But when you go into a hospital, no matter what you have done, you have blood work, you have surgery, whatever it is, and whatever parts they may take out, but the results of that, you need to walk out with a disc. You need to get your information on everything that you have done. It's yours. You're the patient. It belongs to you. I have a call at home, my little cancer closet, and every time I go to the doctor and I come home, I want to know what it is. I want to know it's there. You never know. Doctor can retire. He could leave. You need another doctor. The hospital closes down. This is yours. You move. You take it with you. They can compare one to another, whether it's your mammography, your pathology report. We have got it approved by the federal government that your pathology report is yours. And you could talk to the pathologist. You need to know what your information is, from blood work to anything. You go for mammography, they cannot charge you more than $25 for a copy. You get a copy of that mammography. And when you leave, that's yours. It belongs to you.
Okay, thank you so much. We just have this. We want to give everybody a hand, just our panel, our auspicious panel, a hand for the personal stories, for the wealth of information, for the organizations here. Awesome. We want to just say, in your packets, there is an evaluation form. We want you to fill out to let us know what you think. And we know that this was an awesome, excellent occasion, our 21st Annual Breast Cancer Forum. Thank you so much for participating this year. Okay, so in the hands of our Deputy Supervisor Gooseby.
I think they deserve a big hand, a big one. Excellent, excellent, excellent. Certainly, I cannot say thank you enough. I think all of you have done a fabulous job, and we certainly appreciate it. And I'm certain that out of the people here, you have really touched their hearts, and they're going to be able to use the information that has been given to them today. So thank you, thank you, thank you. Okay. We have one more thing that I have to do. And so we've had this part of the program, and I think some people want to eat. But before they do that, I have to do something that I didn't do. And I have Reverend Monica DeCastro, who's here, the pastor of First Presbyterian Church right here in Hempstead. She was not able to do the prayer for us before, but now we're going to do it, and it's going to be better because we're eating. So would you please come up?
Can everyone hear me? I usually can project well. Amen. Can those in the back, can you hear me? Yeah. So, should I do the benediction and the blessing of the food? Does that work? All right. So, I want to just bring greetings from Christ First Presbyterian Church, located at 353 Fulton Avenue. Want to thank Deputy Supervisor Dorothy Gooseby for having us here for this wonderful occasion. And I also want to say that I have taken my mammogram this year. And so I want to encourage all of our women to follow the instructions from this wonderful panel. And if you are scared, take somebody with you. I'm scared, so I bring somebody with me. Amen. So with all hearts and minds together, let us go to God in prayer. Dear Heavenly Father, we thank you for this occasion. We thank you that we pause to acknowledge you. We thank you for the lives that are here, that you have persevered, some from 5 different instances of cancer to 2 and to 1. God, we thank you that your word says that in knowledge our people perish for a lack of knowledge, that we may have knowledge to take care of these bodies. Lord, we thank you for our Deputy Supervisor, our Deputy Superintendent Gooseby, for bringing us here together. We ask that as we depart from this place, that we would go empowered to take care of our bodies, to advocate for our families, to share the message of well-being. We pray that we will leave from here understanding that we have resources and knowledge, and that we have support teams in our local churches and houses of worship. We pray that every hand that went into making this occasion, that they would know that they have done a good job and that they have been received well. Bless the food. Bless the hands that have prepared it. Let this time of fellowship be a blessing to all who have been here. And encourage the heart of our Deputy Superintendent. In the matchless name of Christ the Jesus we pray. Amen and amen.
Thank you. I'm just here for a moment. They have asked me to come to make sure people know I am the town's first or the inaugural poet laureate. And I'm here, I guess whenever I'm here as a poet. I'm here as a woman who supports us supporting ourselves, taking care of ourselves, mind, body, and spirit. This has been such an awesome opportunity to remind us to take care of us. Thank you so much, Supervisor Dorothy. I've been elevated a little bit. It's been a pleasure. Thank you, thank God, you are awesome. And this, I don't know if you're